really, curious to see, because it seems like you're removing less and less on the columella side and more on the lateral side. When I did it, but sometimes I had some widening of the nostril. That was the only problem that I had. Even if I fixed it deeply, but maybe I did it too much. That's why I want to learn more and more from you.
All right.
Well, I think that's an excellent intro, and we're starting to see some more people funnel in. We have a few minutes after the hour, so we will go ahead and get started with tonight's iteration of the Next Generation Editors Journal Club. After our brief summer hiatus, we are back with our regularly scheduled content. My name is Ryan Austin. I'm a plastic surgeon here in Toronto, Ontario, Canada, and I'm the lead of the Next Generation Editor section. And I'm also pleased to be joined tonight by our co-editor, co-Next Generation Editor, Maryam Zamani from Oakville, Ontario, who's going to be curating our discussion. So if there's anybody who has any comments or questions for our authors or discussants as things go along, please feel free to type your questions into the chat box. Also, there's going to be some poll questions that will pop up. Feel free to answer those as they come along so that we can get a little bit of insight into your experience with surgical lip lifting. Because tonight we're going to be discussing an article from the July 2022 edition of ASJ entitled Three-Dimensional Perioral Assessment Following Subnasal Lip Lift, and the accompanying commentary article. And we're really lucky this month to be joined by the authors of both of these articles. So first up, we have the author of the primary article, Dr. Oren Tepper from New York City. And Dr. Tepper is a graduate of the New York University School of Medicine, where he then went on to complete his training in general surgery and plastic surgery, followed by a fellowship in craniofacial surgery. Dr. Tepper now serves as an associate professor in plastic surgery at Montefiore Medical Center with Albert Einstein College of Medicine, where he's also the director of aesthetic surgery and the co-director of the 3D Printing and Innovation Lab. So certainly excited to learn more about his use of 3D imaging and quantifying his results in lip lift surgery. So thank you so much for joining us tonight, Dr. Tepper. Our discussant this evening is Dr. Thomas Gerald O'Daniel from Louisville, Kentucky, who authored the commentary to this month's article by Dr. Tepper. Dr. O'Daniel received his medical degree from the University of Louisville before going on to complete residencies in otolaryngology at the University of Louisville and plastic surgery at WashU in St. Louis. After completing fellowships in facial nerve and paralysis, as well as craniofacial and pediatric surgery, Dr. O'Daniel now serves as a clinical assistant professor at the University of Louisville. And I know that Dr. O'Daniel has a lot of experience and expertise to share with us tonight. And you're going to be seeing a bunch of commentaries on surgical lip lifting that he's authored coming out in ASJ in the months to come. So thank you for joining us tonight, Dr. O'Daniel. Without further ado, I will hand the screen over to Dr. Tepper so he can take it away with his presentation.
All right, Ryan, thank you. I'm excited to do this, and I guess I'm flattered in a way because there's always great articles in ASJ. And, for you guys to pick something like this, which is a cadaveric study on a topic that sometimes can seem obsolete, I think it raises some important issues. So I'm going to share my screen. I have some slides that I've shown at previous meetings, just to sort of set the discussion and act as a springboard. I won't go too much into the specifics of the article itself. We could talk about that, but really just to give some color and some flavor around that. So give me 1 sec. I'm going to share my screen. Let me know you can see this. You guys, have you seen that, Ryan?
No, not yet. I don't have it.
Okay. Still nothing?
Still nothing yet.
Okay, let's try again. Share screen. Start broadcast. There we go. Let's try it again. How about now?
Looks great.
Thumbs up. All right. So these are just a couple slides. These actually came from the Rhinoplasty and Face Symposium from Las Vegas, and there was an interesting session on lip lifting, which I think speaks to the importance and really the emergence of lip lifting across the country and along the world. So just to sort of frame things, when I think about when I learned plastic surgery and was going through training, I feel like a lot of what we saw and a lot of what we heard at meetings and read, and if you look at chapters of textbooks, it looked at the aging face. And we often heard about the eyes and the face and the neck, the brow, etc. But we sort of looked at it with this vacuum in the perioral region. At least that's the way I remember it. And in terms of where emphasis was placed in terms of the aging face and how to correct it. And I think we owe credit to a number of people in our specialty, but in particular to Nard, Appeal, and Ben Simone on their concept of promoting central facial rejuvenation. We're really bringing this to light, and they've done studies to look at that, and we've learned that with age, we see not just a loss of thickness, and this was done from an MRI study, but also lengthening of the lip with age. So when I first started looking at the literature of lip lifting, when you look back to the early descriptions in the 80s, this is, I believe, the first description of it by Harvey Austin, the bullhorn lip lift. But it's interesting, when you look through that article, at no point in that entire description is the word smile, incisor, or tooth edge mentioned. And it really talks about just the length of the lip, but it does so without really consideration of the surrounding tissue. So a few years ago, I was invited to join this group called the Oral Facial Club, which is a multidisciplinary group of not just plastic surgeons, but dentists and other facial specialists. And when I started to understand the way the world of dentistry thought about lip lifting, it really changed my approach to how we consider lip lifting. And I won't go through this, but this was sort of a neat acronym I put together called DOCTOR, really based off this dentist or doctors too. But the idea behind this was, why don't we look at things rather than just lip length or vermilion height, but if we're going to really truly understand perioral aesthetics, and if we're going to undertake patients for lip lifting, we need to at least have a general understanding of dental anatomy, the smile, characteristics of the patient's tooth edge, occlusal cants, and restorative planes. And I won't go through all that, just to say, for the purpose of this discussion, I truly believe lip lifts are a wonderful procedure. They're relatively simple and they're effective, but if not done right, they can look drastically wrong. And to avoid that, I don't think these should be done in isolation. At least these things should be considered, understanding the surrounding anatomy. So just some examples of patients of mine. This was done in conjunction with a cosmetic dentist here in New York named Jonathan Levine. And I think she has a nice result, but if you look carefully, a lot of this was more than just the lip. If you look at that kind of crease below the columella, that has come up somewhat, but this is really in conjunction of establishing the right lip length, gaining some vermilion height, but also changing the whole architecture of the teeth, the smile, etc. As one. Again, here she is in profile, a minimal increase in in lip length, but I think from an overall architecture, you can start to see the rolling out of the vermilion, the increased vermilion surface area, in my mind, in an attractive way. When you look at how things have been described, there's different techniques. For the purposes of this paper, I performed a bullhorn lip lift, which is what I do on patients. But we should mention and note there are other ways to do it. Other people have described ways to potentially hide that incision, take that above the nasal sill and into the nose. And sure, it hides the scar. And we can talk more about this. In my mind, when you look at that picture here on the right, it becomes almost unnatural because you have that glabrous skin of the lip that begins to creep into the nose. So for most patients, I think it's actually a better result just to keep that junction of your alar rim and sill coming in distinct from the lip. We can talk about some of the techniques here. And this is brought up in the paper, various ways to not just lift and resect tissue within the defect, but actually to undermine and elevate in different manners to achieve different results. So that really set the basis for this study. I think there's a lot of things to consider rather than just lifting the lip. And what prompted my interest is there's so many nuances to what's happening with the lip lift that I felt we needed a better way to understand what's actually happening. So really, this paper was meant to just be a beginning, scratch the surface and understand or accept that lip lifting needs to be more than just how many millimeters do we think lip skin or lip vermilion should be, and simply resect around that number. Based on that number, we need to really think about all the other factors that play into perioral aesthetics. And we now have the ability, and I routinely use in my practice, 3D imaging. And so I wanted to begin to be able to do that. So I'll stop there sort of as the background. We can jump into the meat of the paper, but hopefully that gives some color, some perspective as to how this paper came about.
That's great. Thank you so much, Dr. Tepper. And, we've all had a chance to read the article and read Dr. O'Daniel's commentary. Dr. O'Daniel, I'd like to get your thoughts, not only on some of the thoughts that, or some of the points that Dr. Tepper just brought up, but kind of going through the article, what were your thoughts? And one of the things that we think about is, this has been around for 30 or 40 years, as Dr. Tepper showed some of the source literature for this. But really, it feels like, as we were talking about before everybody came on, that this is really just starting to take off and it's almost becoming rediscovered. So for some of those surgeons who may just be learning about this or thinking about it or trying to incorporate it into their practice, how do they avoid some of the mistakes or pitfalls of kind of incorporating this into their practice?
Also, Ryan, what I'm going to do is share a screen and just kind of address those questions, exactly what you just asked, with some slides that I put together, which will help to give you some understanding what I find are the hurdles with lip lifting. I'm going to share my screen and go to, did it come up for you guys?
Looks great.
All right. So, first I want to congratulate Oren and his team for this, because this is really, in aesthetic medicine, it's a step away from opinion-based surgery, because we pretty much are based on my experience, my opinion. And this is truly an objective measurement of something that's being done with our operations. And we need to be coming up with objective data more creatively, just like Oren has done. What he really has shown us is that you can excise with a bullhorn lip, this central lip lift, but you're going to end up with a lot greater lift in that central lip than you do laterally. In fact, it's exponential when you look at the amount of skin that's elevated. When he took 2.5 millimeters of skin out, it was 30% greater lift than he had with the amount of skin excised. And when he went to 5 millimeters, it was 50% greater. And then when he did the undermining, it was even more than that. So the reality is, I think this serves as a great caution about what happens with the lip lift. And it also, I pointed out in the commentary, is that the central lip lift that's been described has minimal impact on the lateral lip, and it gives a little bit of an unusual look. And I think, in my experience, when we first started doing lip lifts, and when I was young 30 years ago, we kind of shied away from it because it was odd looking and people thought they looked like rabbits. And I think that what Oren has done is pointed out the power of central skin excision with this type of bullhorn design. And he also, I think, one of the things to take home from the paper is that Oren was putting a subdermal suture, which will have a tendency to let the nose migrate inferiorly. And if you use a deeper structure, such as the piriform ligament or the preperiosteal soft tissue, you're going to get an even greater amount of lift. So what he measured was probably a little bit of creep of soft tissue inferiorly. So that, I think the point you keep talking about is the power of the central lip, because these are some of the things that made us stop doing lip lifts 30 years ago. This patient, in the commentary, there's a 5-minute movie of how I corrected it. She's had a lip lift, as well as she'd had implants placed in her lip in multiple attempts to make the lip look better. So when we look at the, I think Lambros's article or his study was incredible in the fact that I got the poll in front of it. He shows that really the lateral lip descends a lot more than the central lip. So that lateral depression really needs to be addressed. And if you look at the central lip, it's more deflation than it is going to be the elongation. So this was published recently, and as a good, as an aesthetic result. And if you look at that exaggeration of the vermilion coming across the central, you can see the central's been elevated, but look at the exaggerated slope from central to lateral. And what we're seeing in society today is this central part is shortened nicely, but the lateral point is not being affected. And you can see which, to Oren's point, you look at the whole patient and you look at a young Demi Moore before the lip lift and Demi Moore after the lip lift, and it creates that exaggerated slope, which is somewhat unnatural. And I think I would refer you to this article by Bernd Vanderlee out of Norway and his colleagues, and they did a systemic review, 930 papers that showed that the lateral lip and the corner of the lip is really ineffectively treated both surgically as well as non-surgically. And there really is a paucity of objective data that states that the patients are even happy with what's being done to them. And when you try to do these direct corner lifts, there's an inevitable scar that's present. So I think that based on what Oren has done is what a true scientist is supposed to do. You're supposed to do a research project and you're supposed to develop more questions than you actually answer. Unlike what we've seen through this COVID crisis, he has really opened the door, which gives us the opportunity to ask a lot more questions. So, I think that from his studies, what I'd like to see are the objective effect on the lateral lip and the mouth corner, because he's already proven that we need to be aware of the central lip. And I think establishing a minimal filtral height would really be applicable. And we need to also talk about the differentiation between young lips and older lips. They have totally different variables. And because of this, we also need to determine what are we doing to young patients? How is that going to affect them when they get older? Just like when we're doing treatment for vertical maxillary excess, what are these patients going to look like when they get older, when you no longer see tooth show? And with that, what is the optimal tooth show in an old patient versus a young patient? So these are the questions that I think that this article really asks of us. And I think that, like I say, Oren is to be congratulated. And I think a lip lift is becoming more popular because we suggested that it's very easy. It was less popular earlier because it was easy, but it was also easy to make people over operated appearance. And design really needs to be customized, looking at all the various variables and understand there's a significant risk for this unusual look. And once again, we don't know what this long-term impact is going to be on the aging lip. So I think, once again, congratulations. As a true scientist does, you've asked more questions. You've answered one critical question, which shows what you just see in that Demi Moore picture is that central lip is very easily elevated. The lateral lip is an unknown territory right now.
So Jerry, you can. Sorry, Ryan.
No, go ahead.
No, there's so much there, and I think you're spot on with everything you're saying. And it's nice having your perspective. Having seen where lip lifts first came out and why it took some time to, to take off, and the reasons people were concerned about. I will say this. I thank you for saying the nice comments about studying the objectivity here. I certainly recognize the enormous limitations that it was a cadaveric study, and the tissues don't respond the same. And two of these cadavers were totally edentulous. My worry in this, to be frank, with a study like this, was that people might start to think of this in isolation of it's just lip, skin, lip vermilion. And in reality, it's exactly what you said, which is before you even think about that, you need to look at corner of the mouth and incisor show. And if you have somebody with an incisor show already, and regardless of what their lip length is, regardless of what the vermilion is, regardless of what the ratio of vermilion of filtral skin to vermilion height is, that's a terrible candidate because you're going to have an awful result. And so I think your point about considering almost everything else, because what you're about to do is going to impact only the central lip predominantly, it's a really important one.
I've been taking less and less skin. I worked with looking at the literature, came up with this idea in my mind that 11 millimeter minimal height was what I was going to shoot for. And I've done about 350 to 400 of these lip lifts in the last 3 years where I'm doing a gliding technique. I now have moved my central maximum or minimum lip in some instances where there's a little bit of tooth show in an aging patient. I will leave it as high as 13 millimeters in height when I measure the corner lip with some to avoid that exaggerated lift. And I'm now doing isolated lip lifts where I'm gliding it, and the central lip looks like it's been lifted. It gives you the optical illusion, because when you take that exaggerated slope of aging, then you're getting, it gives you this optical illusion. I mean, think about the lateral lip. The central lip, we know, is attached to the nose. It's densely attached to the fibrofatty tissue, call it SMAS2, which it really isn't SMAS2, but that's what the literature says. And it's densely attached to the edges of the ala. And from the ala out, that lateral lip, the nasolabial fold, is really, there's no attachment. I mean, you have a gingival buccal attachment. So really, you're looking at a concentric aging away from the base of the nose that's going to be concentric away from the midline, rotating back down into the jowls. So that elevation, what I'm doing is counterclockwise rotation, trying to give you the optical illusion of the corner of the mouth coming up. It's not a perfect situation yet, but I think it's opening up a whole new question of how, in fact, does that lateral lip age? The paper that you described about the MRI studies of lip length, I talked to Alex about this. They said the lateral lip doesn't lengthen with age. And I said, well, that just can't be the case, what I'm seeing. And he said, well, maybe the points they were measuring in MRI weren't actually the corners of the mouth. And if you look at Lambros's stuff, it really, the central lip deflates. So your sagittal projection that you're getting with elevation, are you getting it because you're shortening it, or would we be just as well off to be doing fat grafting or HA grafting at the same time we're doing lifting to get that same rotation? Because it gives you the optical illusion on a frontal view that is shorter, but essentially you're rotating the white roll upward, which makes it a short look.
Yeah, the filler point's an interesting one, right? Because the whole perspective of what's that ratio of skin, right, filtral column versus filtral height, or rather vermilion height. If you just made the vermilion height bigger, longer, like you said, you augmented it, you may give the very impression of a lip lift and having not moved actually any points at all, but just corrected that ratio a bit.
It's these variables that make this so difficult. You know, as a craniofacial surgeon, you're dialed in to looking at dentition, dental support, vertical maxillary excess, arch dimensions. But most people don't have your expertise. And so I think what, we really need to be driving forward when we're, writing and teaching lip lift is looking at all these other variables that actually affect the way the lip looks. Because we write down a bullhorn shape, take an excision, sew it up, and you're done. But these multiple variables, they need to be categorized and put into an algorithmic approach.
Yeah, I mean, just to state the obvious, but I know there's different levels of training and expertise on this Zoom. But just to point out, the dentists for years have been making teeth longer to give the impression of a more rejuvenated mouth, right? Because they want to see some incisor show, not realizing we could lift the lip. So, which is why a lot of people end up with very long teeth, and then you smile and something looks very unnatural about that. The flip side is it's not uncommon for patients to come to me who say, the reason I need a lip lift is because I've spent all this money on a new dentition and I can't see it, and nobody can see it.
Mm-hmm.
There's so much to unpack, and I'd like to try and get into a little bit of it at a couple different levels, because a lot of people reference back to these and look back at these journal clubs, and we get so many people of all different stages. So to touch on a couple points, just looking at assessment of these patients. So Dr. Tepper, you mentioned cosmetic dental. How are you staging lip lifts with a cosmetic dental intervention? Say for the patient that comes in, needs dental work, has excess lip length. They haven't had their dental work all done yet. Are you doing that simultaneously? Are you sending them away to have the dental treatment done first and then coming back? What's your algorithm?
Yeah, a great question. So at a minimum, right, we need to ask what's your history, what's your future treatment plan for dentistry? Same way you would for any other procedure we do on the human body. We can't forget that. So, have you done your teeth? Do you have plans for that? Do you have any Invisalign? You mentioned it, Jerry, in your discussion. Just the architecture, even if the teeth start to go from retrocline to procline, that's going to add volume. That's going to change the whole aesthetic. So you need to understand what have they done? Are they in treatment? And do they have future plans? Because that will definitely impact things. But to get a little bit more sophisticated, if I am working with a cosmetic dentist on this, what we will do is we will plan it all out together. Are they Are they going to lengthen the teeth? Are they going to shorten, etc.? I'm going to plan accordingly. We will get them to the stage of the final mock-up. So the dentist will actually put in the final mock-up, but without the final veneers. I'll do the surgery with the final mock-up in place. And then for any small, inconsistencies, etc., it's a lot easier for them to adjust the teeth, obviously, than us to do it surgically.
Great. And Dr. O'Daniel, age is such an important thing. And you mentioned that in your discussion tonight. We don't really know how the lip is going to change when we operate on these younger patients. And we see younger and younger patients undergoing these procedures. So do you have a cutoff? Do you have an assessment limit? How are you determining when is too young or who is a good candidate or not to have this procedure in your practice?
Well, if you Google the word perfect lip, you will see 1.5 billion returns in 0.5 seconds. It is a hot topic. And so when you start looking at attractive lips, the variables, there's so many papers written on how to categorize it. And you see a beautiful lip, you know it's beautiful, but then you start to decide, why is it beautiful? When I see a young person who has an unattractive lip, and it may not be too short, it may be they have buried vermilion, they may have a lack of definition of the filter column, the Cupid's bows, I will design a lip lift in a young person to make it more attractive by trying to affect those variables. And my primary goal is not to make the lip shorter. I have reservations about making the central too short in the young patients. And I see now some of these people that are making the central lip 8 millimeters, 6 millimeters in height. And these people are 20 years old. And, it's kind of sexy looking, I guess, in a way, because they fill it up with volume. But you just look at that and say, it's kind of like, what's the Brazilian butt going to look like in 10 years? What's that lip going to look like? And you can't hide the lip as easily as you can other parts of the body. So I've tried to look at the aesthetics of what a beautiful lip looks like and then try to customize the lift so that it does that. We have along those lines, Mario is on the line. Mario's got 35 years, 40, I don't know the age, but he has as much experience as anybody in the world doing lip lifts. And I'd like to get his perspective on what he's doing today and what he was doing when he first started doing this with Dr. Patenge years ago. Mario, would you mind giving us your input? You're muted.
Oh, we don't have your audio there.
Oh,
There you go.
you hear me?
Yes.
Oh, okay. So,
Oh, I think we can't hear you very well. I don't know if...
Turn your volume up.
yeah,
No, unfortunately, it's very muffled. Why don't we try and work on it, and we will try and get back to you for your input if we can get that sorted out. So, in terms of technique, Dr. Tepper, Dr. O'Daniel, what are you doing now? in terms of your surgical technique when these patients come in terms of design, undermining, muscle excision, plication? Where are you at today with your surgical lip lift technique? Dr. O'Daniel, if you want to go first, and Dr. Tepper.
So I, about three years ago, approaching 3 years ago, I was looking for a solution to the lateral lip, and I saw the modified lip lift that Oren used in his cadaver, which was undermining the central lip. And it didn't appeal to me because I was already dealing with the problems with too short of a central lip. So I wasn't having a problem with scars, so relieving the tension. So it came to me to, instead of undermining the central lip, to undermine the lateral lip, and tried to evert the vermilion and tried to recruit skin. We published a paper in APS a few years ago using the hemostatic net to glide the brow in the subcutaneous plane. And we've been able to glide the brow and the midface in the subcutaneous plane and actually hold it in place with this hemostatic net. So I started off doing just a little bit of the lateral edges of the lip, and I undermine the subcutaneous plane over the perioral musculature, take a wedge of skin around the ala, similar to an alar base resection. And the central lip, I was still taking the same amount of skin that I was taking on my central lip lifts previously. Now I have evolved to taking very little centrally, leaving a minimum of 12 millimeters of height centrally, and really concentrating on elevating the lateral lip. I extend my subcutaneous dissection to the vermilion on the upper lip, to the commissure, beyond the commissure, releasing the marionette line when indicated, over the depressor labii inferioris, the depressor anguli inferioris. And in the patients with aggressive jowls, I will actually release in the entire soft tissue over the jowl fat pads and try to get that concentric rotation back to the nasal base, and then recruit the skin into a new position and hold it there with the hemostatic net for 48 to 72 hours. I suspend the soft tissue to the piriform ligament, which tries to avoid that widening of the alar base, which can occur if you don't get the sutures deep enough. Sometimes I want it wider, and when I want it wider, I'll actually place it a little heavier. I've got about 300 and plus of these operations, and I have it detailed in the commentary in the video. If you click on the video, it has diagrams with all the basic details of how to do the essential operation. And as of right now, I'm happy with the lateral lip position for the most part. I'm very happy with the eversion of the buried lateral vermilion, which is a difficult area to treat. And I'm really tickled with what it helps with the jowls, which are part of which I feel now are part of the lip. In central facial aging, the jowls are part of our recurrence, or because trying to lift that jowl in a facelift is sometimes not as effective.
So I'll be a little quicker with mine. I take a lot of similar principles, Jerry, from what you mentioned. I think it's interesting that you dissect laterally to be able to roll it out more. And that's always been my theory, that if you dissect down centrally, that it's like a window shade, that it will actually roll up more than if you just en bloc lift the lip. I have to say, I am finding that if I am injecting filler and volume and I don't feel like I need to get that turned up or everted and I can get that augmentation, then I will just resect kind of en bloc with muscle. I do deep sutures. I do it down to the ANS, same situation. I do think the alar base does widen and move with it, despite our best efforts. So I think it's hard to isolate the lip from moving up from the alar base moving down as well. So I will dissect rarely, but I have actually moved more towards sort of the en bloc resection and lift.
And Dr. Cervello, did we get your...
Spotty Wi-Fi service in Brazil.
I still can't hear you, unfortunately.
Okay, I'm sorry.
Oh, there we go. That's...
How about now?
That's good.
Oh, can you hear me?
You're great.
Okay. Tell me if you're hearing me.
Yes.
Okay. I think that you've mentioned several very interesting issues. And the last issue that Oren pulled out is the volume. What I've been doing is I've been removing some tissue right below the columella, going from one alar to the other to increase the concavity. Because what to me, one of the most interesting detail is to have a concave upper lip. And I think that the only way we can get that is removing some tissue and fixing the flap into a deeper position. Regarding what would you say, Jerry, I think you are a pioneer in this operation, and I agree with you. But like I was telling you right a few minutes ago, I had some deception with deep sutures because I've seen some widening of the nostril. Would you have any other suggestion to avoid that?
One of the suggestions would, you take less skin lateral, and that's one of the things, the extended bullhorn that goes out beyond the lateral aspect of the ala. Putting those deep, good, secure stitches, I have been able to prevent that. I've only had one patient I've actually gone back to narrow the nasal base, and I did that with incisions intranasal to bring the ala back in. And I've only had one person complain of it to date. But if I look at the pictures, I can see it, but I have not measured it. And I measure right now if the patients are happy or not happy, because that's where my happiness is.
Right, right. Then I posted a question regarding what Oren said about not carrying out the operation in a patient with some incisors show. Sometimes if the lip is long, what would you think, guys, about lengthening the lip, putting some fat grafting into the upper lip and then removing some of the, fat grafting into the vermilion and then removing some skin from the upper lip? Do you think that that could be okay?
Yeah, look, I think if they're really deficient, yeah, we mentioned that before, Mario, and you can create some length in the vermilion, then absolutely you buy some room to get rid of your skin. But that would be a unique scenario where you have a really deflated lip. You're getting length in vermilion only, and then you can come back and take that on the filtral skin.
Well, Mario, what about, what you're talking about with the volume, in most instances, it's going to be an aging face. And I think 85% of the patient doctors surveyed in ASJ said that they use fat grafting during facelifts. And so if you're doing a lip lift and a facelift, aren't you doing fat grafting? And wouldn't you almost always do fat grafting in those circumstances to the lip?
Yeah, I would do fat grafting, but I'm talking about removing just some tissue horizontally, just close to the columella lip junction, very high, almost close to the alar. So I'm not going to influence the upper lip volume. I'm going to put some fat into the lip, but remove just, for, let's say, a height of 3 millimeter, but deep tissue. That will create some sort of concavity. I do this maneuver very often when I do a rhinoplasty and I have some sort of fullness into the caudal end of the columella, and that works very, very well. Sometimes I do remove some portion of the nasal spine to obtain the exact same result, creating a concavity in the end of the upper lip.
Your concavity is such a good point. And don't you feel like in many patients with the aging lip that the horizontal crease has fallen and it almost becomes the cut here marker of exactly where the lip lift is going to end? That crease, which should be up at the columellar base, which has fallen over time. I just more and more, I get the sense like it's almost telling you where the lip lift needs to end because you're going to recreate that cavity by cutting right there.
Right. Yep, agree with you.
And so we'll throw over to Dr. Zamani. You've been looking at the poll responses and the chat box as well. Any questions have come up, and why don't you review what's been discussed so far?
Thank you. It's been such a wonderful discussion. And I think everyone is so entranced by it. We haven't had much action in the chat boxes, but a couple of trends have shown up on our polls, which is really interesting. I think provides room for some discussion. All of our respondents that do perform any form of lip lifts are using the subnasal method. And the part where we're seeing a little bit of this, divide among our participants is one with respect with any sort of muscle manipulation, ranging from not ever touching it to commonly manipulating the orbicularis. And the other point is, of our respondents, interestingly, given just that we were touching upon fat grafting, that with facelift surgery, we're now commonly adding volume. Among our respondents, only most actually are not doing fat grafting. So I think that provides a little bit of an opportunity perhaps for our authors and discussants to comment on how do you incorporate fat grafting, and maybe take us through the basics so that we can help educate our participants a bit more, and also situations in which you do perform muscle manipulation.
Yeah, for me, for manipulation. So what's that, Jerry?
Go ahead, Oren.
So I would say most of the time I don't, other than to remove the bulk that Mario mentions to really core out what's happening below the nose at that junction. At times, if someone really has a deficient filtral column, I've seen even some of the people on this call present the notion of recreating your filtral depth. I actually like to create the filtral column, and we do it with cleft surgery a bunch, where we will put horizontal sutures to imbricate the orbicularis to give the impression of a filtral column. And I will do that for patients if it is a patient that I'm dissecting down to the white roll and elevating up that skin.
And
so part yes, part no.
What kind of sutures do you use for your imbrications?
PDS. I will say, you mentioned sutures. I will say I've moved more towards finer sutures and taking them out sooner on the skin level, because it's frustrating when you get to those track marks. So I find that if you have enough deep sutures, you don't even need those. They're there, and get them out as quickly as possible. I don't use the net. Maybe I should, but that certainly looked interesting in your video, Jerry.
I've been intrigued by it. I've done it now for 6 years in my facelifts, and I sleep every night without a problem. My practice is mostly aging face. My patients have followed my age, and so the facelifts I do 100% get fat grafting. My lip lifts that I've done, we're doing the literature search on it now. Even when I do an isolation lip lifts, it's usually an older patient, and about 98% of my lip lifts have had fat grafting. And my fat grafting, I use micro fat grafting. I will use typically about 1 cc per aesthetic unit in the upper lip, lateral, central, and medial. And I will use fat grafting to try to create filter height in the central lip by vertically infiltrating with a 0.9 millimeter cannula. I also will debulk centrally when there's not enough depth, and put deep 5.0 PDS to close the dead space. I don't use the net centrally. I prefer to have a stitch there that holds it in place for a longer period of time. And the lower lip, I like a ratio of a lower lip being at least 1.5 times bigger than the upper lip. And with the aging face, the lowered mandible and the alveolar ridge in particular, with the crowding of the dental arch, you get collapse of the corners of the mouth, you get retrusion and inversion of the lower lip, and trying to get eversion and volume to stay in the lower lip in the aging patient is absolute. It's almost as bad as platysmal bands to me as it is platysmal bands are to Mario. I don't know how to solve that problem, so I really concentrate on overgrafting the lower lip. I'll put at least 2 cc's per aesthetic unit in the lower lip, and even infiltrate between the mucosa and the orbicularis to try to roll the lower lip out and create some type of buffer that holds the lip off those retrusions of the retruding alveolar ridge and lower dentition.
Jerry, seeing incisor show on the lower lip is equally as bad as not seeing incisor show on the upper lip. I mean,
it's worse. I hate it.
Right.
Yeah. It's that is a telltale sign. Never mind, you can't see the upper teeth. When it's fallen so far, you see the lower gingiva.
I want to do.
Go
I was
ahead.
going to say I want to do Abbey. I was going to say I want to do Abbey flaps on all of them, but obviously, if only.
So as we get to the end of tonight, I'd love to know from Dr. Tepper, Dr. O'Daniel, a tip, warning for pitfalls, things to prevent issues or complications for young surgeons or more practice surgeons who are thinking of incorporating this into their practice. Is there something that we should be watching out for or trying to guarantee success, Dr. Tepper and Dr. O'Daniel?
I think for me, I think it's the point about considering your lateral lip, because it's if you strictly look at centrally and you're tunnel vision and you're saying I need 2 or 4 millimeters of incisor show without thinking of the actual arch and what's happening laterally, I think you're going to end up with that example that you showed that we see all too often.
Yeah, I would echo the central lip, and also I would point out in today's world, even my really aging patients, 95% plus of my patients have had hyaluronic acid injections, and that will severely impact the healing process as far as asymmetries, prolonged edema, and uncertainty of the outcome, because one side will be unevenly filled and they'll come back with an uneven lip. And understand, when you try to melt the hyaluronic acid preoperatively, it seems to me, I don't know that it's been proven, that the hyaluronidase not only gets rid of the exogenous hyaluronic acid, but it also seems to to cause dehydration of the natural tissues, and so you end up with more collapse of your normal tissues. And so the soft tissue appearance of the lips after dehydration before lip lift can really hamper you. So you need to pay attention to the presence of fillers. The second thing is look at the teeth. You can't overemphasize the teeth. I have all my patients preoperatively hold a tongue blade in their teeth, and I take a picture so they can see the occlusal cant. Because if the teeth come back and they're now crooked when they can see their teeth, they didn't see that before, they understand that it's not your lip lift, it's their occlusal cant. And so you need to point that out. All of my patients also, I do complete videos before and after with complete movement of all the perioral musculature in every fashion. Some people have hyperkinesis of one side of their mouth over the other, and that can impact the postoperative result, particularly the way when they're smiling in their phone pictures. So when they come back, you can compare before and after videos to help them understand what you did, and you can also protect yourself by looking at it preoperatively and comparing it postoperatively.
Jerry, sorry, one quick point, Ryan. The quickest way in your exam is just have a patient say like "mama," and then keep the mouth open in repose. It's a few millimeters apart, because we're used to taking their either closed mouth or smile, and we don't have a good sense of what's happening at rest when the lips aren't actually opposed to one another. So a quick shot, "mama," as soon as they stop, that's kind of the position where I think it's best to evaluate.
That's fantastic advice, and we could chat about this all night and go on about the nuances. And this is an exciting article because I think it's a great springboard to discuss lip lifting. I think we're going to be hearing more about it, seeing more about this, and I certainly look forward to Dr. Tepper's next 3D study in the patients that he's operated on. I think it's going to be fantastic, and Dr. O'Daniel's work has stood for itself, and I can't wait to see all the work that you bring forward and and read all the commentaries that are going to be in the pages of ASJ to come. So thank you all for tuning in tonight. Thank you, Dr. Tepper. Thank you, Dr. O'Daniel, for taking the time. Thank you, everybody, for tuning in. Make sure that you tune in to the next ASJ Journal Club. We're going on a bi-monthly basis now, and so that will be in September or in October, and that will be run by Dr. Mark Albert and the Young Aesthetic Plastic Surgeons Group. Everybody take care, stay safe, and look forward to seeing you online soon.
Thank you.
All right, guys. Thanks.
Hi, Mario.
Hello. I think you did a great job, both of you. That was very interesting. The only thing I didn't have the time to ask you, Jerry, is when do you do an excision in the end of the upper lip? You say you've done some. Did I understand well? You go an excision just to avert the right.
Vermilion?
Yeah.
I did it years ago. I've not done it again, but I have 2 patients that the vermilion is still buried. I'm going to try it. This Ben Talay has done a number of these, thousands, and he says that the scars are good, and he does a little like right out to where it's buried. So I'm going to try it. My memory of what the scars looked like before, it's still kind of in there. Have you done it yet?
No. That's why I was very curious, because I'm afraid about doing it. But as you said, you know, the story of the upper lip reminds me the one of the brows lift. For years, nobody has done it, and now there are a lot of people who are calling me, writing to me, and say, "What we want to do it? Give us some suggestions." So I really think it's something. That happens in aesthetic surgery. There are some operations that they explode at a certain time, and they conquer a lot of success. And for 20 or 30 years, nobody was doing it. I think you are really popularizing this operation. And the article that Oren wrote too, it's a very interesting article. So I think all of us are following your advice, and you should still discover new issue and help us with all these different problems.
I'll do that. You figure out how to fix this platysma problem, and we'll call it even.
Each of us has some frustrations, you know.
All right. Thank you, guys.
Okay,
Take care. Thank you all so much.
Thanks,
Thank
Abby.
you, Zamani.